Hi, how are you, Ted?
I'm fine, thanks. How are you doing?
Good, everything fine. I'm finishing the morning. GMN.
Perfect.
Cool.
How did it go? How did it go today?
Interesting cases, many MCI cases, biomarkers. It's getting interesting. Yeah.
Nice.
Thinking how to, if we can start to do anti-amyloid therapy here. So we're still not ready, but some patients need it. So we're trying to going into that direction.
This is a topic today that has more questions than answers, and so welcome you to come in and talk about any part that you want to talk about.
Definitely. I'm not 100% convinced either, but I have young patients who have positive biomarkers, and it's all over the news. So, what to do is a good question. Yeah, especially
Right.
for us. We are, definitely. I also have questions. Yeah. Mhm. So, is Emma going to introduce you, Ted?
I think so, but if not, I'm happy to do that myself. And
No, I can do it, but I don't remember everything. If you want to show it, you want to send me what you want me to read, and then, or maybe you have it somewhere. I don't know.
let me see what I can find.
Yeah. We have 2 more minutes. Yeah. Cool. Did I tell you that they have the guide at Grady?
I'm so excited about that. I heard that news.
Yeah, so happy. Very happy.
Hey, Dr. Johnson, this is Stacy Hanna. While you're looking for that information, I heard you last week. It was so wonderful.
Oh, thank you, Stacy.
Thank you so much.
That was the funniest I think I've ever been. So I hope that was okay.
It was great. I loved it. And because I do a lot of work with clients as well, I was like, you spoke language they could understand. Thank you.
Thank you.
I really appreciate it.
Hey, thanks for coming on, everybody. We're going to get started in just 1 minute. Hey, thanks for joining, everybody. We're going to give folks just 1 minute to join. Thanks for joining Georgia MemoryNet Insights, GM Insights today. Excited to have you here. Welcome your participation. There'll be a couple of ways for you to participate during today's session. And looking forward to a great conversation. Hey, thanks everybody for joining Georgia MemoryNet Insights. We're going to start in just 1 minute. Thanks so much for coming.
Ted, do you have your slides?
I do.
Good.
I'll go ahead and get them ready.
Excellent.
Does that look okay? Can you see the slides all right?
Perfect.
Great. All right, Dr. Cohen, I'll let you start. Thanks so much, everybody, for joining today.
Hello, this is Gabriela. Thank you so much for joining us. I'm very excited to introduce today to my friend, Dr. Ted Johnson. Dr. Johnson is a primary care core lead for Georgia MemoryNet. He is professor and chair of the Family and Preventive Medicine and chief of General Internal Medicine. He received his MD from Northwestern University Medical School and his MPH from the University of North Carolina School of Public Health in Chapel Hill, North Carolina. We are co-directors of this course, and today I'm very excited. We're going to be talking about getting permission to assess mental status. Thank you so much, and back to you, Ted.
Thanks, Dr. Cohen. Hey, thanks so much, everybody, for joining today. This is going to be a talk where I have more questions than answers, and so I recommend that you. I encourage you to participate. We're going to have a couple of chat quizzes as we go along, and so looking forward to that. With regards to this talk, I have no disclosures or commercial conflicts of interest. And so I'm going to start with a case. And this first case is a 74-year-old male who says that everything's absolutely fine. He says he's completely able to take care of himself, and he has no concerns about his memory or thinking. And he is seeking admission to an insurance-based continuing care retirement community where his wife has been approved for admission. So a bit about myself. I've been involved in geriatric medicine since my training at Chapel Hill. I've been fascinated by mental status assessment and questioning, and I'm very interested in the patient-provider relationship as well. And so I hope that those are shared interests for you. So this is an interesting scenario where people are being evaluated by me, in this case as a geriatric fellow, to make sure that they have nothing going on at the time where they would be a risk to the continuing care retirement community. I'm not the patient's provider. I'm actually an examiner. And so, as you might imagine, that brings up all sorts of conflicts in terms of the assessment and what they're trying to hide and what you're trying to find. And so, while this is not your usual patient-provider situation, it brought up lots of memories for me, and I did about 60 different tests of folks who are seeking admission to a CCRC. And that was what led to this kind of phenomenon where people actually wrote the answers to serial subtractions from 7 from 100 on their arm and actually tried to read it during the examination. So there's a number of different things that you'll find online where people can get the mental status assessments that they're going to be given so that they can prep and test for it. And so let's go to the next slide. So for learning objectives for today, I thought we would talk about 4 different topic areas. One is kind of like, how do you demonstrate care and concern? How can you be comfortable so your patient will be comfortable? How do you frame the results? And then finally, this plan of what you're going to do next is a really important part of starting a mental status assessment. So part of demonstrating learning and concern, I'm going to walk through a couple of these and we'll do the last 2 together. And so here's your first quiz. I'm going to ask you to put this in the chat, your answer, and then I'll count off to 3. And so you can hit your answer all at the same time. So people reading the chat will see just a different cascade. So this is something that I found in the family medicine literature when physicians were eliciting patients' preferences, meaning that they were saying, I'd like to know what you think about this. The average time elapsed before the provider then turned around and interrupted the patient was go ahead and length of time, don't hit return just yet. So type into the chat how long you think, in this case, a physician allowed their patients to talk in response to a question that they were asking before they interrupted. And so if you've gone ahead and typed in your answer, go ahead and I'll count off to 1, 2, 3. Go ahead and hit return. Okay, so we've got a few seconds, 3 minutes, 30 seconds, 1 minute, 5 seconds, 15 seconds. All right, so let me give you some choices in case you want to vote again. Which one of these 5 choices, one of them's the right answer? When physicians were eliciting a patient's preference, the average time elapsed before interrupting the patient was, and go ahead and enter a number and hit return. 7, 11, 22, 10. Yeah, so the answer was 11 seconds. That was the average time that it took for someone to interrupt a patient when they had asked them to provide an answer to a question. So one of the things, the 3 to 234 seconds was the total range of time in these recorded interviews. This is an interesting paper in case you wanted to find that and share it with friends, or if you're teaching learners. It's a good paper that sort of shows that wasn't the purpose of why they collected the interviews, but they were looking at the solicitation of preferences and they were struck by how quickly someone interrupted. I think that when I teach the physician assistant students and the nurse practitioners and sometimes the medical residents, the points that I bring out about this is that it's oftentimes when you're listening to someone spontaneously talk or answer a question or provide you details or just your chit chat and story, oftentimes you'll find that that content that they give you is either timely, specific, detail rich, or other times it's kind of vague. And every once in a while, you see something else happening in the room. Let's go ahead and talk about this next part. So this is something that the physician assistant students here at Emory are looking at when they are learning about how to do the interview with the geriatric patient. They've paused this video and don't use it anymore, but they used it for a number of years. And this is a pretty good video for a number of reasons, but I thought that some of the things that they did about mental status assessment were kind of interesting. And so here's the first observation that I have. Oftentimes you're in a room with more than one person. You're in a room with both a patient and a care assistant or a care provider or a family member who's providing care for that person. And so one of the things that I noticed about this tape is that it's really kind of filmed as a movie, meaning that you could see everybody in the same shot. And oftentimes your kind of how you triangulate the room, so to speak, is a little bit different. The other thing that I noticed is that there's no computer in this room. It's just a discussion. So this is one of my favorite clips with a couple of folks that you might recognize, Dr. Law and Dr. Hales and Laura Metters. And so I'm just going to play this little video. You might not be able to hear the sound at all, but I want you to watch kind of what's going on here. Dr. Law asks a question of Dr. Hales, who's portraying a patient. And if you saw something happen, go ahead and write it in the chat. Laura Metters is playing the caregiver. This is Chad Hales playing the patient, and Jim Law is playing the doctor in this scenario. Play it one more time for you. The question that Dr. Law is asking Dr. Hales, who's portraying the patient, is you've been managing this all by yourself. And Dr. Hales, being the patient, says, yes, I have been. And Laura Metters, as the caregiver, is giving you the exact no. And so there's a lot of rich content in the interview when you see both people together. There's one thing that you say sometimes that puzzles the patient. Sometimes they'll turn to the caregiver and ask a response. And so there's a lot of different ways that this can manifest, but I think it's a rich opportunity to kind of see kind of what the content answers and the like are for the patient during the evaluation. And so one of the other things that I think a lot about in my evaluations in patients that I'm seeing for reasons other than mental status assessment, I'm just seeing them for some general primary care issue, or in my case, I'm seeing them for some sort of bladder control problem, is I try and set up my room in a way in which I can look directly at the patient, but also catch a peripheral view of what's going on with the caregiver. And then sometimes I'll often pause and say, is it okay if I ask your wife the same question? Is it okay if I ask your son the same question? And try and fish out a little bit about whether I'm getting the right information. I think that the other couple of things to talk about are that in demonstrating your concern are just explaining fully what it is that you're trying to do and what the purpose of administering the test is, and actually asking explicitly for permission. And so if you, I'll tee up something in the chat in just a second, and so ask you for some more input. This next part is being comfortable with the instruments that you're using and why you're using them and what you hope to achieve so that other people are comfortable as well. And so this is a second case of a patient that I was seeing for continence care. He was having bowel control problems. We weren't getting very far with our evaluation. And so at one point he said, I just don't feel right. I'm having trouble getting my medication straight. Sometimes my memory is not what it should be. And I looked back and to see whether or not anybody had done any past assessments. And there had been somebody who had done a mini-cog. And basically the results were not fully available, but they were reported as abnormal. And so that's about all I had to go. And so I used a script that I often use. And that script kind of goes, do you feel that you have problems with your thinking or memory? Do others say that you do? And then would you mind if we did a memory and thinking test? And then after I say that, I usually say something that has to be true and resonant. I do this with nearly all of my patients. For me as a geriatrician, that's often true. But I wanted to ask you to type out in the chat, and don't hit send just yet, but type out in the chat if there's a script or a little phrase that you use before you begin to do some sort of mental status assessment with your patient. Go ahead and type that into the chat. I'll give you about 10 seconds to do so. And then after you've had a chance to type that into the chat, go ahead and count down. 3, 2, 1, hit send. Is it okay if we test your memory? I'm going to do a memory assessment that I do in every patient. If you didn't have a chance to type it in the chat, some sort of script or scriptlet that you use, feel free to come off of mute and offer a response. What is it that you say before you give some sort of mental status assessment to your patient or memory test to your patient?
This is Annie. Can I add it?
Yes, please go ahead.
So I sometimes also tell people that this is women the first time I'm doing a test also to get a baseline for future. So it's not, especially when doing screening, that this isn't to label you with a diagnosis, which is often people's scare.
Thanks for that. So you tell them that I'm getting to know you. This is our first visit, and I always want to do a baseline assessment. Okay, thank you for that. Carolyn Clevenger, your name says Meredith Sawyer, but you can't fool me. Do you want to offer any sort of what phraselet or snippet you use?
Yes, I was writing a paragraph instead of a sentence. So my thought is, this is a symptom like any other. So if you had a cough, I would ask additional questions. I would gather additional information. Can they hear me? Yeah.
Yes.
And so this is a symptom they're experiencing. I should look into it, and it's helpful for me to know what's going on so that we can put together a plan.
I like that. So you want to find out what's going on. You want to get some ideas of where they are, and you want to use that in order to execute a plan. Great.
Hi, this is Dr. Somayajula from the Gainesville Clinic. And
thanks so much for joining. We're so excited to have you as part of the GMN family. And we know you're doing great work there up in Gainesville.
oh, that's so sweet. Thank you. Sometimes when I'm talking to a patient or a family, I say, there are reversible causes, many treatments for memory now. So it's helpful for us to get an idea what your memory is like so that we can attack and understand and treat any reversible causes like B12 deficiency or thyroid. And that usually puts them at ease.
Thanks for that. So that notion that, hey, look, there's something that we plan on doing to help you as a result of doing this. And there are ways in which medical care has changed significantly such that there are some treatments that might be very useful. So thank you for that. And Carolyn, writing is Meredith, you said, like a cough or any other symptom, we should evaluate further. It's helpful for me to know what's going on so we could put together a plan. That's great. One final additional answer. Anyone want to come on and say what's their script or scriptlet that they use before they start testing?
I think we can go on, Ted.
Thanks. So a couple of things to think about. One is to pick a tool. And then oftentimes when you're learning how to treat something with a medication, you often pick a second medication in the same category. And so here's the tool that's most frequently used, that's quickly teed up in some of our Emory clinics as well, to use the mini-cog. It's an easy scoring system and it's pretty easy to administer. You give 3 words, and I'll tell you that there's a list of recommended words that can't be strung together, like an apple and a pie and a slice of cheese type of thing, that, you know, somebody could create one sort of one singular image for those 3 words. So there's 3 registered words, then a distracting task of a clock drawing, then followed up by recall. And so a couple of these tests have recommended words, and version 1 is banana sunrise chair. Version 2 is daughter heaven mountain. And so I always encourage you to use the same 3 words. I've been in a situation where I used different sets of 3 words, and then I can't remember what 3 words there were. And so that's quite embarrassing. And so I often use apple, table, penny, but banana sunrise chair is recommended for this task. In the mini-cog, and there's, if you haven't looked at our library of past Georgia MemoryNet Insights videos, a very good one from David Loring, our neuropsychologist, went through both clock drawing as well as cognitive screening tests. So in this case, the clock drawing that's done for the mini-cog, you actually spot the person every step of the clock specifically. So you say, here's your circle, draw the clock, and then put in all the numbers, and then show that it's 10 minutes after 11. So you give each of those sequentially, and then you go back and ask for the 3 words that you registered. I love David Loring's comment that the clock is only recorded as normal or abnormal. There's a lot more information that's in clock drawing that you can pull out, but in this case, you're just looking for basically, is it normal or abnormal? And so in this case, his mom, as he calls the mom role, his mom would say that these are abnormal clocks, both in terms of the spacing that's on this one, and also the fact that this clock goes counterclockwise. Always good to know what was the time on the clock that you asked for, to just make sure that that's right.
And sorry, Ted, it's important to use standardized tests. Not all the words have the same difficulty in remember. So usually sunset is like more abstract and it's much more complex. So if you want to change and different using versions, you need to use the validate words. It's not like any word, okay?
Really helpful. Thanks so much. And these are those validated words. And so if you go to the instructions, and I've left one reference for how you would do that, you can actually use the 3 validated words, and you could do different versions if in case somebody were to write on their arm what the words were, just like my patient did. So what's your second tool? I'll give you just a second to write that in the chat. If you use the mini-cog, what do you use for follow-up? What do you use next? What's the second most familiar tool that you're using? Go ahead and type that in the chat. And then 3, 2, 1, hit return. Mini-cog, Mocha, others, Mocha. So I did use a Mocha in this second patient that we were discussing, but I wanted to refer you to this article. You can follow the QR code. This is from the National Institute on Aging, and it recommended some screening tools that I hadn't used very often. One that several people on this call have used, and one that I hadn't used much. And so the patient that I saw in clinic, where he's like, I just don't feel right, we went through kind of a script, trying to make him feel as comfortable as possible. He was willing to do the test, and his total was actually better than I expected, given that he had failed the mini-cog, and that he got 26 out of 30, which made me think about other things that were going on with him and not just primarily cognition. He did take 2 attempts at the cube, and that constructional apraxia thing is very worrisome when it comes out as an early fail on one of these tests. And the fact that he did very poorly in delayed recall was also worrisome. So this was an assortment of test errors that was kind of odd to me. One point on calculation, he missed an early number, and then all the subsequent numbers were normal. And so we had 26 out of 30 for him. And then I'll refer you back to kind of what I saw in this NIA article about what other tests might you use, because I thought, well, some of these other tests might be useful. And so raise your hand. I can see some of you. Raise your hand if you use the AD8 dementia screening interview test. A couple. Yeah. And so I kind of like this for a couple of reasons. One is that this may move you upstream, so to speak, in detecting mild cognitive impairment. It's not, no single screening tool is perfect, but this asks for a participant to endorse, yes, they've experienced a change over the last several years that have been caused by thinking and memory problems, including judgment, less interest in hobbies, repeating the same things over and over, the same stories, the same questions, trouble learning how to use a tool, forgetting the correct month or year, trouble handling financial affairs, difficulty with appointment remembering, and daily problems in thinking or memory. And for this patient that I saw in Continence Clinic, where our main focus wasn't on his memory assessment, these were the problems that he was having a lot of difficulty with. He was repeating the same stories, having trouble getting through his day, having difficulty with his with remembering different things that were going on through the day, including appointments. And so this gave me a more positive signal than the MOCA did on this patient. And the other recommended test in that NIA article was also the Quick Dementia Rating System. Raise your hand if you used that. I didn't find people who had used this before, but again, one of the directions that it points us to, as opposed to the AD8, which fits on one page, this QDRS Quick Dementia Rating System ends up extending over about 5 or 6 pages. These are free to use. They're not free to put in your electronic medical record, but you can say that you work in a health system and you plan to use them in patient care, and you can get paper copies of these. Whether or not this actually helps us all that much is not all that clear, but at least in some patients, it might be a signal when you're not getting another signal from an assessment tool before you go to a full evaluation. I really like the trail making B test, especially for assessments around driving. I think that this is a good rapid tool for that purpose. I do talk about the trail making B in a lecture, and I give one of the students in the lecture a laser pointer and have them do that. You can really tee up somebody for their not best performance if you don't relieve their anxiety and talk about it. And if you talk specifically about this as related to driving, people probably get really nervous before they take the test. And so figuring out how to be honest about that and get a fair test of performance. Framing the results, I think that we probably do less than we should about framing the results. And sometimes I feel that focusing on people's abilities rather than all of their deficits is actually something that allows you to do that next step. And what does this mean and what do we plan on doing? This had a very strange, in the training of a training clip, a very strange phrase of your body's like a car, you just lost 2 of 8 cylinders. I find that analogies are probably not that helpful, especially not if you're not really familiar with your car and its cylinders, and I don't know. And so broad proclamations from screening tests are probably inappropriate. And the point is to figure out how we can help and what additional information that we need. Knowing what to do next is really important. If you look at some of the literature over the past 10 years about screening and mental status assessment in primary care, I worry that a lot of it's becoming very quickly outdated because of many of the different things that we're doing in assessment and evaluation and potential for treatment. And so these thoughts of what is the point of doing something, what would I do anyway if there's a positive result and nothing can be reversed, I think are things that are really not the same premise of the literature of screening primary care that we saw. So, and driving is interesting too. I think that the Alzheimer's Association position on driving is very nuanced. It's basically saying that everybody should have a plan for driving retirement, and based upon the fact that at some point in a course of progressive cognitive impairment, that eventually you'll get to the point. But It's hard to find out people who will be able to do and expensive to figure out how to do all the driving assessments that are probably function and context specific for driving. It's not good to let somebody drive too late, not good to retire them too early. The future is a blank page. It's hard to figure out kind of what's going on. I know that in some of our clinics in primary care, we're working with Linus tablets to do measured cognitive screening assessments in primary care, figuring out how to take all those people that we're finding that are positive and getting them the detailed evaluation that they need to have in order to figure out whether they're a candidate for disease modifying treatment if it's early Alzheimer's disease or mild cognitive impairment. So appreciate you coming on to talk about this. I'm going to leave this up for a second so that people who want their CME the old-fashioned way can go ahead and answer the question. And at the end of the Qualtrics questions, you get a chance to click in and get your CME. And I see it, Pam. And then also you can also go on and get CME by text by signing up and then texting 18056 to the Emory CME office. And so
And
I'll
we
go
have
back.
a few, sorry, Ted. Yeah,
Yep.
we have a few questions.
Perfect. Go ahead. And Pam, go ahead with your question, then I'll look at the chat.
Okay. My question is a little bit of a comment as well. I have been doing more of my own memory testing in my office based on these talks, and I feel very empowered to do so. But I noticed that then when I try to send patients to neurology, I'm getting an e-consult back saying that I've done enough testing and that this person wouldn't benefit from neurology consultation. And I guess I really want, as a primary care doctor who's not trained in geriatric medicine, I would love for patients to be followed by a neurology even once a year to think about new therapies, medication management, social work, which we don't have otherwise in outpatient primary care. And I've had a few other primary care doctors who I've talked to about this and have said something similar. And I feel like this is going to create this very slippery slope where primary care doctors don't want to do the testing themselves because we don't feel equipped to manage these patients long term. And especially, we don't have resources like social work.
You want me
Pam, I
to
heard your
answer?
question. I'm also responding to, oops, sorry. I'm also responding to the surveys not working. So let me see if I could put the Qualtrics survey in. Sorry, I re-put my introduction back in. I didn't.
I can answer to her if you wanted.
Yeah, go ahead. And
Okay, that's an excellent comment. That's why we create Georgia MemoryNet. The idea is that you could have an assessment anywhere we are in Georgia, refer the patient to us, we'll do a cognitive assessment, and we send the patient back to you with the most likely diagnosis and at least with some recommendations. So I think that if you as a primary doctor, you are concerned about something and you think that the patient needs to have a full assessment, I think that's good enough. I mean, I definitely entitled to, and that's why I think that doing a dementia-specific interview and a cognitive assessment, if the primary care doctor suspects something, I think is good enough, and we should do it. Even if you have a negative mini-cog. Remember, the mini-cog as a screening test has a sensitivity for dementia, not for minimal cognitive impairment. So if you're suspecting minimal cognitive impairment, you're not going to diagnose dementia based on a mini-cog. You need some further tests, and that's why we're here to help.
Dr. Cohen is one of the lead physicians down at the Grady-based MAC. And so Pam, for your position being in Emory Clinic, there's one option current and the second option maybe coming up up soon. There's going to be a second memory assessment clinic that's going to be at Hillendale Hospital that is actually modeled after the Georgia MemoryNet assessment program. And so I think that if you don't have a DeKalb Fulton County resident and you have somebody else that you want to send to another Emory clinic, that Hillendale clinic should come up and running. We do have several folks on this call from other Georgia MemoryNet clinics across the state, and so that's awesome. And then Carolyn, you and I had a very brief conversation about other things that are going on. You and Gabriella Cohen are both going to be guide programs, and so do you want to maybe say whatever you'd like to say publicly about the different things that are going on in the background?
Yeah, so I think we've gotten some, we've also been on the receiving end of some referrals with a similar process, Pam, where someone has done an evaluation in primary care, which is a perfectly appropriate place to do that if you have the bandwidth to do it. And And then the e-consult came back similarly that this person, has, confirmed dementia syndrome, right? Maybe there's not specific biomarkers and maybe that's not appropriate for that person for whatever reason. And then they're sort of back to primary care to manage. And I know that there are some challenges with bandwidth with ongoing neurology care for those patients as a consultant. Certainly, we've received people into integrated memory care for ongoing care with that social work, nurse triage, and other components to the team. We are a guide site and established program, which means that in July, so 3 short months, we'll be enrolling traditional Medicare beneficiaries for a comprehensive dementia care approach, which is everything we do today, and then additional benefits, including respite. So we'll see, I think, after May where those other sites are. I think there are 2 other new guide sites who will be starting in July of 25. So there's some long-term options. And then there are some discussions about what do we do in terms of that more of a in-between from someone who, like, there's been some preliminary work in primary care. Either they're not appropriate or not appropriate yet for the full cognitive neurology, very specialized, amazing diagnostic work that they do. There's sort of this in-between space, and we're trying to figure out a solution to that. And I know not everybody needs to come to IMC or wants to come to IMC, but we do have bandwidth to see patients. We don't have a wait list. And so if that's appropriate for patients, I'll just make sure people know that that's available too.
Pam, your question about, so I do this and then what's the point? I think that that's one of the punchlines that we've had for a long time. And I think that if you can't get the care for your patient, now that you've detected that there's a problem, it's the same sort of dilemma that we were in before. So thanks for that great question. Carolyn and I were talking about another thing before this talk, and that was kind of a 2/3, 1/3 rule. So Malaz Bustani did some work maybe about 10 years ago about how many people that they did a screening test on when they were sent to someone to get a full evaluation actually went. No waiting line, right? Just like, you should have this followed up. How many people went? 1/3 went and 2/3 didn't. In that 1/3, 2/3 sort of matches with some of our Georgia Memory Net connection to social work services within the community. 1/3 takes advantage of it immediately and 2/3 don't. And so you will find things that people will turn you down on. Here's the next thing for you to do. And so that's one of the difficulties that we sometimes have. Other questions or comments? Thanks for that great question.
Great comments.
Dr. Parker, it's great to see you. Thanks for the great work that you're doing in the community. Really appreciate you. Thanks for joining us today. Thanks everybody for joining us. Any final comments?
I think no more questions. Emma put the right link. So for the CME, if you look under yeah, we have here the right link if you need to submit the CME. Yeah, under the chat. Thank you. Thank you all for joining us. Okay, thank you so much, and we'll see you next month with another lecture of this series. Okay, thank you so much.